What's up, Microbiology Nerd Squad? Welcome to another video. Today I'll be teaching you about urinary tract infections. So let's begin. Urinary tract system. The urinary tract system consists of kidneys, ureter, bladder, and urethra. The kidneys not only play a key role in urine production, but also have various other functions such as filtration of blood, waste excretion, regulation of blood pressure, pH, water balance, and electrolytes. The urine produced in the kidneys is then transported to the bladder via the ureters and finally excreted through the urethra. Urinary tract infections, UTIs, are common infections that affect parts of the urinary system. UTIs are categorized as either being lower or upper tract infections based on the location of the infection. Predominantly, they are caused by bacteria, but other pathogens can also be involved. Symptoms include a strong urge to urinate, a burning sensation during urination, cloudy or strong smelling urine, and pelvic pain. UTIs can be treated with antibiotics, but preventative measures such as good hygiene, staying hydrated, and urinating after sexual intercourse can help reduce the risk. If left untreated, UTIs can lead to more serious kidney infections. There are risk factors that predispose patients to developing UTIs. These include gender. Due to having a shorter urethra that is close to the genital tract, females are more prone to getting UTIs than men. Pregnancy. As a result of hormonal and anatomical changes, UTI risks in pregnant women increase. Use of catheters. Long-term use increases likelihood of biofilm formation, which protects bacteria from the immune system and antibiotics. Sexual activity. Increased activity increases chances of bacterial contamination of the female urethra. Diabetes. Due to changes in the immune system and high sugar concentration, risk of UTIs increase. Renal transplant or urinary procedures can cause introduction of bacteria into the urinary tract, leading to infection. Immunosuppression weakens the body's natural defenses, making it more susceptible to UTIs. Fun fact. Did you know that your bladder can stretch to hold up to half a liter of urine for several hours before you feel the urge to go? Sample types and collection. The microbiology lab receives a range of urine sample types for various investigations. These include midstream urine or clean catch urine. This is the most common type of urine received. Early morning urine, often collected and best suited for TB investigations. Catheter urine, slightly more invasive, but may allow collection of bladder urine with less urethral contamination. Bag urine, received frequently from young children and infants, and has the highest rate of contamination with fecal or genital flora, but is commonly used because of its non-invasive method for collection. Suprapubic aspirate, known as the golden standard urine, as it's less likely to be contaminated with skin and genital tract organisms due to how it's collected. Prostatic massage, collected by massaging the prostate, and can be used to diagnose bacterial prostatitis. Terminal urine, last portion of the urine passed. This is usually required when testing for the presence of schistosoma species. Nephrostomy urine, usually taken when there is a blockage in the lower urinary tract that may prevent normal urine flow. The urine collected is considered sterile, therefore any growth is clinically significant. Urostomy urine, just like a nephrostomy sample, it is collected under sterile conditions to avoid contamination. The urine is collected into a urostomy bag which is attached to a stoma. The stoma allows urine to be diverted from the bladder through an alternative route. Important protocols for urine specimen collection. The container must be sterile. Usually a clinician will provide a sterile universal bottle along with a test request form. Because urine is an excellent supportive medium for growth of various bacteria, it must be refrigerated to prevent overgrowth if the sample is not being tested within 24 hours of collection. To bypass this problem, the clinician may provide the patient with a red top universal bottle containing boric acid. Boric acid is used as a preservative by preventing overgrowth of bacteria. Using this allows for sample preservation for up to 96 hours when refrigeration may not be possible prior to testing. Sample volume collection is also an important aspect for testing. Between 20 to 30 ml is the recommended volume of urine to provide for optimal results. Sample labeling. Once the sample is collected for testing, it must be labeled with sufficient patient information before processing. This is to ensure that the correct diagnosis is given to the correct patient. Unlabeled specimens are automatically rejected, as we can't be certain which patient the sample belongs to. Urine microscopy. Initial testing. Urine dipsticks are used in a variety of healthcare settings such as GP surgeries, hospitals, urgent care clinics, and even at home as part of a routine checkup to assess overall health. Due to their portability and ease of use, they're regularly used to screen signs of a UTI and monitor existing conditions such as diabetes. Nitrate reductase and leukocyte esterase tests are both used as a screening procedure for UTIs. High number of white blood cells in urine often indicates the presence of an infection. However, because it can also be associated with other clinical diseases, it isn't specific to UTIs. It is important to note that a dipstick is used as a screening tool, and abnormal results should not be taken as a definitive diagnosis. Further testing is required. Manual microscopy. The inverted microscope is routinely used to analyze the contents of urine from patient samples. White blood cells, red blood cells, casts, yeast, bacteria, crystals, sperm, and epithelial cells can all be identified using this microscope. Automated microscopy. In larger laboratories, where a higher number of specimens are received, the workload is managed by the use of automated urine analyzers. These analyzers have the ability to quantitatively detect different elements in urine samples and processes large volumes efficiently, allowing faster turnaround times for the test results. Some analyzers have built-in microscopes and image processing software to identify a wide range of particles in urine samples. These results are usually automatically transferred onto the computer system, where a scientist uses it to make decisions based on the evidence provided. Urine culture. Two common methods are used to culture urine samples in the lab. Manual method. This requires a lab assistant or scientist to inoculate a urine sample onto the relevant media type under sterile conditions and incubate the medium to encourage growth of microorganisms associated with UTIs. Chromogenic UTI agar is especially used for this purpose. Cysteine lactose electrolyte deficient agar, also known as CLED, is an alternative media often used for diagnostic urinary bacteriology. Other alternative media for urine culture include blood, McConkey, or sometimes colistin nalidixic acid agar, also known as CNA. A sterile 1 microliter loop is immersed into the urine and cultured onto the agar plate. A larger loop, for instance 10 microliters, is recommended to detect a lower number of organisms in certain specimens, for instance nephrostomy samples. Automated method. Automated systems for urine cultures are advanced laboratory instruments that streamline the process of culturing and analyzing urine samples. Automated systems can process multiple samples simultaneously, requiring minimal user interaction and allowing for quicker results compared to manual methods. Interpretation of results. Interpretation of urine culture results involves analyzing various factors to determine the presence and significance of bacterial growth, potentially indicating a UTI. These factors include presence of microorganism. No growth can indicate absence of an infection, but it can also be due to prior antibiotic use or improper collection technique. Growth of an organism can indicate an infection. However, this also depends on the quantity. The number of bacteria colonies grown in the culture is measured in colony-forming units per milliliter of urine. A high CFU count is more suggestive of a true UTI compared to a low count. The purity of the culture is an additional factor. A urine sample with mixed growth of different microorganisms, for example, isn't considered significant to follow up. Sample type or site of urine. Any growth from urine samples considered sterile should be worked up despite low numbers of CFUs. Type of organism. Some bacteria can be harmless contaminants around the urethra, while others can be considered pathogenic when grown on a urine culture. Staph aureus, for example, is significant regardless of the number of CFUs, whilst Staph epidermidis, which is a skin flora, isn't. Clinical symptoms. Symptoms often associated with UTIs along with growth of bacteria in the culture strengthen the case of a UTI diagnosis. Clinical details. Catheter use, pregnancy, immunity status, age, and previous recurrent UTIs are all relevant details to consider for an accurate diagnosis and treatment plan. Microscopy results. Presence of red and white blood cells along with growth of bacteria can indicate an infection. Laboratories establish their own criteria for interpreting results to determine true infection from contamination. Treatment. The disc diffusion method is used for sensitivity testing on urine samples. The set of antibiotics used for susceptibility testing is solely dependent on the type of organism present in the culture. Common UTI pathogens that require follow-up work include E. coli, responsible for 60 to 90% of UTIs, coliforms, such as Klebsiella pneumoniae, Proteus species, and Enterobacter species. Enterococcus species. Enterococcus faecalis is often found with coliforms in cases of chronic infection. Staphylococcus saprophyticus, prevalent in young women. Group B streptococci, important in pregnant women. Staph aureus and Pseudomonas species are both associated with surgical procedures and catheters. Other microorganisms with the ability to cause UTIs include Candida species, common in intensive care unit patients. Adenoviruses, associated more with bladder infections and common in immunocompromised individuals. Although not a true UTI, the parasite Schistosoma hematobium can affect the urinary system. It can lead to blood in the urine, painful urination, and increased urinary frequency. UTIs are commonly treated with antibiotics such as trimethoprim, nitrofurantoin, ciprofloxacin, augmentin, and more. The choice of antibiotics used to treat UTIs depends on the specific bacteria causing the infection and the patient medical history. A patient will in most cases be given antibiotics when a UTI is suspected prior to sending a urine sample for culture. This is to help relieve the symptoms of the condition. The presence of the antibiotics can be detected using culture plates by viewing the growth pattern. The first inoculum shows no growth on the plate, but growth can be seen after. Further work can be set up to identify resistance mechanisms such as ESBL, AMP-C, and CRO. These terms all refer to enzymes produced by bacteria that specifically target and break down certain antibiotics. By inactivating the antibiotics, the enzymes effectively render them useless against the bacteria that produce them. Extended spectrum beta-lactamase, also known as ESBL, is an enzyme produced by some bacteria, most commonly E. coli and Klebsiella species, that cause penicillin and cephalosporin antibiotics to become ineffective. A keyhole pattern is observed between antibiotics cefpodoxime and augmentin. Sometimes the keyhole pattern is not clear or visible on the sensitivity plate. This is when additional sensitivities are set up. AMP-C beta-lactamase is another type of enzyme that can break down some beta-lactam antibiotics. AMP-C resistance is less common than ESBL resistance. The presence of either ESBL or AMP-C can complicate UTI treatment by limiting effective antibiotic options. Carbapenem-resistant organisms, also known as CROs, are bacteria that have developed resistant mechanisms to carbapenem antibiotics. Carbapenems are often used as a last resort to treat serious infections caused by multi-drug resistant bacteria. CRO resistance is less frequent in UTIs but not uncommon. Time to test your knowledge. Can you remember the maximum volume of urine a bladder can hold? Make sure to leave your answers in the comment section. Thank you guys for joining me on another episode. Please make sure to like, comment, and subscribe. See you in the next one.